everybody, it's Crystal
and Allison.
For our capstone project, we wanted to focus on the laryngectomy community and their singing abilities and limitations. The name of our project is Singing After Laryngectomy, an Electrolarynx Case Study. Just to give you a little background about laryngectomies, the primary function of the larynx is to prevent aspiration and penetration. It plays a vital role in the respiratory tract, allows air to pass through, and keeps food and drink from blocking the airway. Its secondary function is to produce sound from the vocal folds. If anything happens to the larynx due to damage or disease, then producing sound becomes difficult and for some non-existent. The most common cause of a damaged or diseased larynx is laryngeal cancer. Laryngeal cancer accounts for about 1 to 2% of all cancers. The most common treatment for advanced stages of laryngeal cancer is a laryngectomy, which is when all or part of the structures in the larynx are removed. Those structures are arytenoids, cricothyroid, etc. When all of these structures are removed, that's called a total laryngectomy. And when less than the total structures of the larynx is removed, it's called a partial laryngectomy. Once the larynx is removed, producing sound no longer comes from the vocal folds, so alternate communication needs to be considered. The rehabilitation process of a laryngectomy focuses on reestablishing functional communication through the use of alaryngeal communication. The three most common types of alaryngeal communication are artificial or electrolarynx, esophageal speech, and tracheoesophageal prosthesis. An artificial or electrolarynx uses an electronic device as the sound source. When this device is used, the metal or plastic tube is placed against the stoma, and the device transmits respiratory air from the tracheostoma to the mouth, which produces sound. The articulators are then used to shape the sound and produce intelligible speech.
Esophageal speech is an intrinsic method of voice production where the individual inhales air into the esophagus and then releases that air to flow into the pharyngoesophageal segment, or PE segment, where sound is generated. This typically sounds like a belch or burp.
Tracheoesophageal prosthesis, or TEP for short, is a surgical option where the surgeon connects the trachea and esophagus with a small puncture and inserts a one-way shunt. Being vocal requires the individual to inhale air through the stoma and into the lungs. The individuals must cover the stoma with their fingers so that the air from the lungs can be directed to the trachea, through the shunt valve, and into the esophagus. The air causes the esophagus to vibrate, producing a sound source for speech.
These three methods allow sound production for individuals without a larynx. However, in comparison to the laryngeal voice, the vocal quality is low, typically monotone, hoarse, and in the case of an electrolarynx, robotic sounding.
Devices are constantly being enhanced to add prosodic features to alaryngeal speech. It should be noted that rehabilitation does not just focus on the physical and functional changes, but these changes can also lead to a negative impact on psychosocial well-being. Therefore, treatment cannot just focus on communication, but on quality of life as well. Just to give you some background on why we're interested in the laryngectomy community, for me, during undergrad, my favorite class was voice and fluency disorders. Not for the fluency aspect, but for the voice. I found that laryngectomies were so interesting and unique. And one day during voice and fluency, we had a guest speaker who was a laryngectomy, and he used an electrolarynx. I was so intrigued by his story. When he was diagnosed with laryngeal cancer, he got a partial laryngectomy. However, his cancer came back, and he had to get a total laryngectomy. He explained that once he had his total laryngectomy, he was not able to communicate besides writing. He decided to use an electrolarynx to communicate, and he stated that his SOP did not know how to train him or how to use the device, and he basically had to teach himself. This is not the first time I've heard a laryngectomy say that their SOP was not much help when it came to alaryngeal communication. Therefore, on that day, I decided I want to work with this population and become competent in alaryngeal communication so that when I do work with this population, I'll provide them with the information and training they need to communicate functionally in daily life.
My interest in this population began with my background as a singing actor. I was already interested in the voice, but when I took the voice and fluency class in undergrad, I discovered that I was very interested in the single class that we had on laryngeal cancer. I expressed this interest to my mother, who reminded me that my paternal grandfather had had a laryngectomy. In World War II, he became addicted to cigarettes, and unfortunately, that caused him to acquire laryngeal cancer. Due to that laryngeal cancer, he had to have a total laryngectomy. My mother said that he did not enjoy using his electrolarynx because of the robotic sound. He preferred to use a stoma. Unfortunately, he died when I was 2 years old. However, this personal connection furthered my interest in the laryngectomy population.
We have selected 3 articles to review that will be beneficial for our capstone project.
I will be going over how do voice restoration methods affect the psychological status of patients after total laryngectomy, and electromyographic control of a hands-free electrolarynx using neck strap muscles.
And I will be going over the effects of singing training on total laryngectomies wearing a tracheoesophageal voice prosthesis.
While the other 2 articles we address are experimental in design, this is descriptive research and provides insight into the impact that each method of alaryngeal speech can have on patients' psychological health. A year after laryngectomy, 96 patients maintained participation in this 2016 study. All subjects were smokers prior to their surgery. Of those 96 subjects, 11 patients continued to smoke after total laryngectomy. This study excluded laryngectomy patients with a premorbid psychological diagnosis, as well as those who had speech therapy services since their surgery. 24 patients used esophageal speech, 57 had a TE fistula and used a Provox 2 prosthesis, and 15 used an electrolarynx. 3 tests were administered to determine patient quality of life: Voice Handicap Index 10, Perceived Stress Scale, and Hospital Anxiety and Depression Scale, all of which have been translated and validated in Turkish. This study found that the preferred method was esophageal speech. This is likely due to the fact that esophageal speech does not require assistive technology and is therefore less visually conspicuous. Esophageal speech also removes the financial stress of having assistive devices to maintain. One of the most salient strengths of this study is that it compared all 3 alaryngeal speech options for patients. Some of the strengths were already addressed in the previous slide, such as the financial stress being removed, and also not having a conspicuous device to carry around, monopolizing the use of one hand. A weakness is how few women were included in this study. Of the 96 participants, only 6 were female, with 2 in the esophageal group, 4 in the TE fistula group, and none in the electrolarynx group. Another limitation of the study is that, aside from those with a psychological diagnosis, the quality of life tests were not administered to the patients before laryngectomy to determine if their levels of stress, anxiety, or depression were already high prior to surgery. Another limitation is that such a study may have limited external validity for Americans due to cultural differences between America and Turkey, especially concerning the prevalence of smoking. This prospective study centers around the use of electromyographic hands-free electrolarynx. It concluded that a key aspect of the hypothesis being explored on the use of EMG-EL failed to produce results. 3 patients underwent an experimental surgery for targeted muscle reinnervation, placing a transplanted recurrent laryngeal nerve branch on the distal side of the neck where it had not been preserved in the original laryngectomy. Recordings were made of each participant using EMG-EL with natural, post-traditional laryngectomy innervation, and again with EMG-EL following the reinnervation surgery. The transplantation of this recurrent laryngeal nerve branch was not found to have any effect on the responsiveness of the EMG-EL technology, and therefore posed no greater prosodic benefit for the 3 patients than a traditional laryngectomy would have provided. Since every surgery carries risk, Kubert and colleagues concluded that the TMR surgery was not worthwhile to improve prosodic control of the EMG-EL device. The success of targeted muscle reinnervation for amputated arms and legs formed a strong rationale for attempting application using the recurrent laryngeal nerve. Though this is successful in gross motor function, it was concluded that TMR may not have the same applicability in regions of the body with such complex fine motor pathways as the larynx. Overall, the greatest strength of the study was that it showed what did not work to further the advancement of a hands-free, prosodically advanced EMG-EL technological device.
For this last article, the experimental study assessed the effects of singing training on the voice of total laryngectomies wearing tracheoesophageal prosthesis, TEP. With this assessment, they analyzed the quality of, the vocal extension of, and the musical elements of tuning and legato of the alaryngeal voice. 5 laryngectomies completed the singing training program over a period of 3 months. After the singing voice training, all participants showed an increase in vocal extension and started to present tuning abilities, as well as most presented grado legato, which is just smoothly sung musical notes. The strengths of this study include all participants were trained under the same conditions, and pre- and post-training testing was completed. All participants were submitted to singing training consisting of a weekly trial of 30 minutes for a period of 3 months, so 12 sessions in all. Participants were instructed to emit the vowels A, I, and U after inspiration in the same tone presented on the keyboard. They were also asked to sing Happy Birthday to You to analyze muscular elements of tuning. These parameters were analyzed before and after the 12 training sessions by 3 independent singing teachers with at least 3 years of experience. Pre- and post-training testing provided evidence that singing training improved the voice quality of TEP users compared to no singing training. There were some limitations of the study. They had an extremely small sample size and a low inter-rater reliability rating. Only 5 participants, 3 male and 2 female, were used in the study. Having a small sample size leads to a large margin of error. Another limitation is the inter-rater reliability rating. Inter-rater reliability was determined regarding the categorical variables of each parameter by calculating the percentage of concordant and discordant ratings, and a minimum of 68% reliability was achieved. For most studies, 75% inter-rater reliability is acceptable. Even though the study's reliability comes close, due to their small sample size, it would have been more beneficial if their reliability rate was higher.
The primary complaints the patients gave about electrolarynx use is that it dominates the use of one hand entirely. Their other complaint was that there was not enough prosodic variation, which resulted in a robotic and unnatural sound.
Some common themes in the research were that most of the studies, they had a small sample size, women were unrepresented, and further research needs to be done.
Piggybacking off of the idea of more research being needed, the research that we have now brings us up to date on where science currently stands with the possibilities for the electrolarynx. The first study, the descriptive research, lets us know how electrolarynx stacks up against other alaryngeal speech methods and which factors most impact patient psychological health when an electrolarynx is used. The second study on electromyographic electrolarynx brings us up to speed with the cutting-edge EL technology so that we can see what scientific breakthroughs may be on the horizon for this method of communication. The expanding prosodic capabilities are of particular interest because that will impact potential singing capabilities with the EMG-EL device and other electrolarynx devices.
As for the last article on singing training for laryngectomies, this article is useful because we need evidence that supports singing abilities in laryngectomies. This is a relatively new concept, so there's still a lot of research that needs to be done in regards to the strengths and limitations of singing abilities in laryngectomies, but this is as far as modern research has gone.
This leaves the door open for us to begin our single subject study. The combined information from the 3 articles gives a multifaceted view of the effect and affect of alaryngeal speech and singing using an electrolarynx. The purpose of our study is to learn from one man's experience singing with a true-tone electrolarynx, how his singing background helped him figure out how to use the prosodic features of his electrolarynx, the extent of his formal training in singing before surgery, and any other alaryngeal speech methods he tried before choosing the true-tone electrolarynx are all of interest and will help us understand where the research needs to go from this point onward. Using our single subject's experience in conjunction with our background research, we will determine how closely an electrolarynx can approximate natural singing. We will also determine the difference in patients' perception of quality of life when singing is restored, if that is indeed a possibility.
Our single case study will be conducted with Mr. Tony Talmadge. Using the true tone electrolarynx, Mr. Talmadge taught himself how to use the device and sing while doing it. He now does conferences. He was recently at the ASHA convention, and he even has a YouTube channel where he teaches others how to sing with these devices.
In addition to our interview with Mr. Talmich, we will review all current evidence-based research on electrolarynx advancements so that we can examine up-to-date options with prosody and singing options after total or partial laryngectomy. We will integrate the information from this interview and this research to draw a conclusion about whether singing is a viable option for total laryngectomies. Our hypothesis is that past experience with singing, either formal or informal, assists total laryngectomy patients in optimizing the prosodic features of their electrolarynxes, even to the point of being able to sing again. We look forward to being able to relate the results of our research.
These are our references for our capstone. Thank you so much for watching and listening to our video.
This has been Allison
And Crystal.
signing off. Oh, wait, is that still on?